I thank Dr. Madhu for letting me share my little experience with all of you. And I thank Dr. Manjunath for his kind words. I've been told to talk about first 6 hours, how do we treat patients in the ICU after a transplant? And then I put forward my little experience. So I always look at like this. Anyone who is less than 10 kg, though they are small, but the smaller the patient, the bigger the trouble always. And anything for that matter. And then all patients who have the need for a transplant, the basis is you have to remember that the cirrhotic physiology does not change immediately post-transplant, and then it is very difficult to kind of differentiate between cirrhotic physiology and sepsis which has been there with the child pre-op and then post-op as well. So the other most important one when we talk about the first 6 hours after transplant is any child with liver disease, they do have some amount of third spacing depending upon their liver disease, how well they are prepared pre-op or not, and then whether they walk into hospital from home or from the ITU or from the ER, of course not from ER, and then this third spacing increases post-op because of the surgery, because of mechanical ventilation, and then because of the large graft size and the abdomen size mismatch, the abdomen is tend to kept be open for a short while, and then because of the gusseted state of the abdomen, it is difficult to quantify the fluid loss in the post-op. And then, as I just mentioned, they do have persistence of deranged physiology, which is most important with the kind of shock called a distributed shock, which persists post-op in the best of centers. So when there is persistence of this kind of distributed shock, which is associated with decreased peripheral vascular resistance, and then because of so much amount of nitric oxide circulating in them, and then with cytokines, they do vasodilate with whatever amount of vasopressors you give as well. And all this will lead to some element of relative hypovolemia, which is difficult to manage even post-op as well. And then the gross principles of in the first 6 hours or 10 or 12 hours you call is we have to maintain the vascular patents of the graft at every cost. Our outcomes depend upon the betterment of the graft at any cost. And then to maintain the patents of the graft, we have to aim for normal or maybe supraphysiologic blood pressure to ensure perfusion of the graft at any cost, provided you are not causing significant systemic hypertension. Please remember this. And then to maintain proper perfusion of the graft, it is nice to talk to the surgeon what kind of anastomosis and what kind of collaterals does the child have intra-op. And then for all this to happen, never try to push up the hemoglobin. And as Dr. Prem was mentioning, who might be the candidates for early extubation in the operating room is a question of debate, especially when the child weight is less than 10 kgs. I tell myself always, whenever you're talking about or whenever you do intensive care, you have to extend the kind of care what you deliver in the OT to the ICU, at least for the first 6 hours or 12 hours or even after that as well. That would decide that the graft is well taken care of, well perfused, and then well maintained. Ideal team, as mentioned, as you can see with the surgeon, I would put that it is nice and safe to have the transplant anesthesiologist as a part of the ICU team to take care. And then all these three people should have a high index of suspicion of hepatic artery thrombosis and even portal vein thrombosis in the first 6 hours or 12 hours. And then we have to give attention to the smallest detail. The first 6 hours is dictated by the issues because of primary disease, be it metabolic or be it extrahepatic atelectasia or Wilson's or otherwise. And then not to forget that if the child has got metabolic disease, that it would have caused distant organ dysfunction like in adults. And then, but to pick up distant organ dysfunction in kids less than 10 kg, it needs lot of clinical skill compared to adults. Because in adults, we have other parameters like cardiovascular, DAC or PFT to pick up, but that doesn't happen with kids. And then because of the age does not match with the weight in kids when they undergo transplant. And then the type of graft, whether it's deceased or live, and then the graft size as such. And then other important is we tend to see kids who are fully covered because of the loss of temperature. Kindly examine the child with the clothes off. Then you will know whether the child is frail or well nourished. And then other important thing, what we have learned over time is that aspects of size mismatch of the graft. If, intra-op, the surgeon says that the left lateral segment looks like a flat fish, that would fit into the abdomen very well compared to like a puffy fish where the AP diameter is too big to fit into the child's abdomen. And then if the child has undergone previous CASI, the child tends to bleed a lot, and then they do have a lot of additions. And then not to forget that if it's large for size, they would have serious graft edema for the first 6 hours or 12 hours, which would dictate the provision of the graft. And then if the IVC clamp was for more than 60 minutes or even 90 minutes because of difficulty of surgery, that would add to a lot of small bowel edema mainly. And this small bowel edema will make it difficult for the surgeon to close the abdomen. And then because of some element of congenital disorders, there will be some element of small dystrophic body trouble, which would not allow the graft to fit. And then if they do have extrahepatic biliary atresia, the size of the graft are too small. So that please remember, that's the reason why you need to talk to the surgeon whether they had any difficulty with the grafting of the artery and the vein and the hepatic veins, and then the need for heparin intra-op or not. And then a bit more about LFS. So whenever we talk about LFS, it acts on the cardiovascular, respiratory, GI perfusion, and then most important thing is the carbon dioxide load, which all of us see in the post-op, which is measured like at least more than 50% of kids who undergo transplant with LFS, they do have hypercarbia, which persists for 6 hours or 12 hours, even more than that, and it is beyond difficulty to bring down that carbon dioxide load. As you see in the slide, the point is there? Nobody yet? Sorry, go back. Large graft, low portal flow, which will lead to some amount of relative graft ischemia, which will again lead to trouble, and then which will add to graft edema as well. So this cycle has to be broken. So there are no ways to improve the portal vein flow unless and until the number of collaterals have been identified. No, pointer. And then if there is a large graft, there is ongoing ischemia, reperfusion injury, which persists for 6 hours and or even 12 hours as well. And then mind it, once the graft is reperfused, there is an element of warm ischemia continues, provided we don't perfuse the liver with more than supraphysiologic pressures for the first 6 hours, then the chance of lactate rising is too high, the chance of hyperkalemia persists. And remember the last one, higher metabolic demand by the regenerating graft persists whatever you do. And then all this will add to threefold risk of arterial thrombosis. This is just a slide which will tell you the pathophysiology of LFS in the first 6 hours post-op. If you look at the extreme left of the slide, the respiratory complications what we face is in terms of increase. Pointer. I don't know. Okay, fine. Extreme left of the slide are the respiratory complications in terms of high peak pressures, high carbon dioxide, and then in spite of you increase FiO2, it is difficult to manage the PaO2, and then if you increase the rate as well, along with the minute ventilation, you cannot wash out PaCO2 because you will start having auto-PEEP. And then all this will add to severe metabolic acidosis along with hypokalemia. And then the other important thing is pediatric multi-organ dysfunction syndrome, which persists from pre-op, intra-op and the post-op as well. It is a continuation of physiological disturbances, but unless it is picked up very early, it would push us into a point of no return where we'll end up in septic shock because of the MODs, especially with the cardiovascular and respiratory. If you see the incidence of MODs as calculated by the PRISM score or PLOD score post-op, it is nearly 25%. If you come down, what factors will add to the MODs post-op? We have fluid shifts, reperfusion syndrome, and then vasopressor overstimulation because of their physiology as well. And then we tend to transfuse more than 50% of the blood volume intra because of the child's weight and then large surface area. And then we tend to cause metabolic acidosis unknowingly because of hypothermia and then low hemoglobin as well. And then hyperkalemia happens commonly because of hypovolemia. Please remember this. It is very easy to tell that the child is hyperkalemic, but we tend to forget that we always do not take care of hypovolemia as well. After we have successfully done surgery, we are preparing ourselves to transport this child to the PICU. What happens when we transfer the child? So they do have something called as motion-induced hypotension, drop in blood pressure, the moment we kind of shift the child from OT onto the transport stretcher, and then we tend to have disconnection of the lines of the syringe pumps, and then, as mentioned in the previous lecture, once the size of the ET tube is cut, the chance of reintubation or extubation is too stiff, and the loss of endotracheal tube is nearly 3.70%, which is too stiff. And then there are incidences reported that they have done CPR on the trolley as well. What gross principles which any PICU physicians has to follow is constant monitoring of the graft quality and function in terms of sugars, lactate as well, maintain adequate fluid balance, and to detect thrombotic complications at the early phase, to prevent infection, and to pick up early organ dysfunction. And the immediate post-op physiology is dictated by the etiology of liver disease and whether the child had ascites or not, and then was the child too sick for transplant. We tend to transfuse a lot of volume in terms of crystalloids, colloids, blood, FFP. Are these going to really change our management in the post-op? Yes, they do change. Then how are we guided by this? To transfuse, all of us you do take a rotum or lab as well, but unless we know the etiology and the brief of the surgical steps, it is difficult for us to gauge or to travel along with the pace of the surgeon. And what factors would dictate from the pre-op to the post-op is whether the child had fulminant liver failure or not. Was the child malnourished? Most important, because unless we examine the child with the clothes off, we will not pick up. And then, did the child have any multi-organ failure? And then the etiology of the disease, and most important, any previous surgery. This slide will tell you grossly about, if you look at the green one, extreme left, target decrease in serum lactate at any cost. And then if you start having normalization of lactate, then only you are sure that the graft is functioning. If you travel down to the red one, do not hesitate to ask for an abdominal ultrasound, or if you have any element of doubt about the Doppler of the artery or the portal vein, please go for a CT scan with contrast or without contrast to pick up early detection of hepatic artery thrombosis, and then also to know for any active bleeding. And then extreme right under neurology, a few centers, as Dr. Prem mentioned, they are willing to extubate the child on table or within 6 hours or 12 hours, depending upon the center preference. But I would wait for at least for 6 hours or 12 hours, especially for kids who are less than 10 kg, because their oxygen demand is too stiff, nearly 300% of the normal needs. I found this useful, which all of us have to practice. There's something called a fluid creep. which happens pre-op, intra-op and post-op. That is, we tend to administer all drugs which are diluted with saline. So, all of us know that saline contains sodium and chloride and water. We tend to push a lot of sodium, chloride and water unknowingly or knowingly as a vehicle to give fluids, to give drugs and to give infusions as well. So, this will add to the amount of sodium load and to the amount of hypervolemia. So, maybe we can try to concentrate the drugs as much as possible and on a daily basis to indicate what kind of fluids and then why do we need to give fluids at all, and almost to learn, like all of us have been learning about antibiotic stewardship, is something called a fluids stewardship for all the PIC people who are treating transplants. And then unless it is indicated not to display a CVP, because whenever you have a display of a CVP trace or an RTL trace, you want the catheter to be patent, so you tend to give 2 or 3 ml of saline every hour. So, this adds to sodium load as well. And then when we talk about diuresis for a child who is 10 kgs, we will tell, okay, the patient is fluid overload, we will give a diuretic. So, we should ask ourselves, why am I diuresing this patient? For what sake? Whether to decrease the fluid or to decrease the potassium or to decrease anything else. And what is my fluid goal for the day? See, to decrease 50 ml every hour or to decrease 100 ml every hour or more than that. And how much fluid I want to remove this day, whether in 4 hours or 6 hours. If you have difficulty in removing fluids, please consider CRRT, which is very safe as well. If you have chosen a fluid goal, are you going to give a direct bolus or an infusion? I would prefer an infusion as well. But and the last line, all of us are trained, starting triggers for fluid resuscitation are quite clear, but we are not sure about the stopping triggers. And then if you want to prevent hepatic artery thrombosis, if you want your graft to be perfused well, intravascular volume to be maintained, but how do we do this? We don't have any way to measure the cardiovascular function except to measure lactates, to measure CVP and to measure the urine output. And most important, at least 60 to 70% of patients post-transplant who are less than 10 kg, you see them after one day, the sodium is 150, 155, 160. And then the other most important thing is what kind of fluid we use to replace the drain losses. Some centers prefer 5% albumin, some centers prefer FFP. It's a matter of discussion. And then their need for glucose is too stiff post-op. And if it is good to be on the hyperglycemic side to an extent, and then don't think of not to use insulin. Please use insulin. It is a very good drug as well, apart from being hypoglycemic agent. And then to end off, now, this is a combination of a team which will take care of a patient post-op as well. And then the last one, direct mechanical compression by the recipient abdominal cavity on the coastal margin, on the diaphragm and the nearby organs, that is the aorta and the IVC, because of the large graft plays a very big role in managing the mechanical ventilation, whether to decide to extubate or not. And then if you see the one which is highlighted in green, the patients in early extubation group were more likely to be older than who are less than 10 kg. Please remember that. Not to take home the message that, okay, we will extubate all kids on table. It is nice you extubate, but please remember that you are only giving one thing, that you are only decreasing their duration of mechanical ventilation. You are not decreasing anything else by extubating them early. So I would tell that if I am on call, I get a call from the nurse because these are the red flags. Persistent NCAF, the child is not waking up after stopping sedation, and there is persistence of metabolic acidosis and increasing in lactate, and then low blood pressures, and then there is persistence increasing in the drain output. Then either they are bleeding or they are hypercoagulated. And then if I prescribe an intravenous fluid, I need to know the quantity, the type and the sodium content of it. So the three principles which I follow in my practice is to aim for decrease in serum lactate, and then see that how early we can normalize serum lactate. And then if you can measure systemic venous saturation, and then try to understand the portal vein flow. And I close with this. It takes a lot to treat the little, and we don't know what the caterpillar will go into, but we know unless we treat the first 6 hours and 12 hours the child very well and then take care of the graft, the child will grow to be a beautiful human being. Thank you for your time.